Seniors. Good evening, sir. My topic for today is pre-op preparation, risk assessment, and anesthetic plan in patient with cirrhosis posted for Lienorenal shunt. Primarily, Lienorenal shunt is a surgical procedure to lower portal venous pressure. Shunting is done between distal splenic vein and left renal vein, as in selective shunting. It sometimes involves proximal splenorenal shunt, which involves splenectomy, which is not commonly done nowadays. Pre-op preparation starts from history of presenting illness. We have to look for complaints of platypnea, orthopnea, history of blood transfusion, drug or substance abuse, especially alcohol intoxication, abuse, tattooing history, past history and family history of jaundice to be asked. Examination, we should look for icterus, halitosis, parietal enlargement, gynecomastia, spider angioma, clubbing, astrosis, altered sleep-wake cycle, hepatosplenomegaly, and hepatic encephalopathy. Investigations, routine blood investigations starting from CBC. We should look for hemoglobin for anemia, platelet count, WBC count for infection, blood urea, creatinine, nitrogen for a pre-renal azotemia, a hepatic renal syndrome, random blood sugar, LFT for bilirubin, albumin-globulin ratio, electrolytes for dyselectrolytemia. Common dyselectrolytemia is hypokalemia, hyponatremia due to diuretic use. Elevated PP-INRs can be commonly seen in these patients. ECG for dyselectrolytemia and dysrhythmias. Chest X-ray to look for right-sided pleural effusion. Echocardiogram for pericardial effusion or and also for ejection fraction. Preparation, we have to optimize nutritional status of the patient. Hypoalbuminemia correction with IV human albumin injections. Vitamin K, phytomenadiol injection 10 mg IV OD for 3 days in case of elevated PT-INR. We should consider FFP transfusion pre-op. Fluid restriction, diuretics, especially potassium sparing diuretics. Paracentesis for severe ascites. Pre-op antibiotics for infection control. Prophylactic H2 blockers starting 4 to 6 weeks before surgery for anti-aspiration and gastritis prophylaxis. Lactulose and neomycin if hepatic encephalopathy is present. Cryoprecipitate and desmopressin for in cases of prolonged bleeding time. As an anti-aspiration prophylaxis, we usually administer ranitidine injection 1 mg per kg IV and metoclopramide 10 mg IV. As a routine pre-op order, we should avoid sedation in cases of hepatic encephalopathy or cases prone for hepatic encephalopathy. Inform the written consent in view of prolonged mechanical ventilation, ICU care, and transfusions. Risk assessment grades of we have to evaluate hepatic encephalopathy. There are 4 grades of hepatic encephalopathy, each based on level of consciousness, intellectual fineness, neurological findings, and EEG. Grade 1 involves lack of awareness and personality change. There may be short impertination and mild astraxis. EEG shows slowing and triphasic waves. Grade 2, the patient will be lethargic and inappropriate behavior and he will be disoriented. He will have astraxis or and abdominal reflexes. Grade 3, patient will be asleep, drowsy but arousable, loss of meaningful communication. Grade 4, patient will be unarousable, lack of attention, and he may be in decerebrate posture. EEG will be showing delta waves. There are 2 commonly used scoring system in a cirrhotic patient, which is Child-Turcotte score. The criteria involved in CTP scoring are albumin, bilirubin, INR, ascites, and encephalopathy. Starting from albumin, if the albumin level is more than 3.5, score is 1. 2.8 to 3.5, score is 2. Less than 2.8, the score is 3. Bilirubin, less than 2, score 1. 2 to 3, the score is 2. More than 3, the score is 3. INR, less than 1.7, the score is 1. 1.7 to 2.3, the score is 2. More than 2.3, the score is 3. Ascites, No ascites will be graded as 1, slight ascites graded as 2, moderate ascites 3. Encephalopathy, none as a score 1. Grade 1 and 2 will be given as score 2. 3 and 4 will be given as score 3. So as a total, we can get a number as 5 to 6. That is a class A well compensated cirrhosis. Class B 7 to 9 scoring total score. Class C decompensated. The total score will be 10 to 15. This will predict the patient for 1 year as well as 2 years. Patients with patients 1 year survival will be 100%. 2 years survival is 85%. Class B 1 year survival is 80%. 2 year survival is 60%. Class C 1 year survival is 45%. 2 year survival is 55%. And there is another scoring system model for end stage score, which involves serum bilirubin, serum and serum creatinine as a calculating criteria. MELD sodium is the recent predictor score scale, which includes serum sodium in addition to the above mentioned criteria. So this predicts is following a liver transplant. Shows 1% mortality, 10 to 9 to 29 shows 20%, 30 to 39 shows 52%, more than 40 scores 71% 90 mortality. So after predicting the management, initially have to plan for GE. After the consent and adequate theatre preparation, after shifting the patient, standard ASA monitoring for ECG, pulse oximeter, a non-invasive BP, temperature, and a qualified trained anesthetist in the presence of qualified anesthetist. We can go for an arterial line for ABG analysis and glucose analysis. Central venous access for volume resuscitation, point of care coagulation profile monitoring. After all this, we can go for induction. Induction should be rapid sequence induction to avoid aspiration. Choice agent is propofol in titrated doses. Sorry, pre-patients, we can go for a glycopyrrolate, benzodiazepines, midazolam, and induction agent propofol. Opioids should be fentanyl and remifentanil. It is not completely dependent on liver for elimination and metabolism. Inhalation agents, O2 plus air, halogen compounds like isoflurane, sevoflurane. Halogen should be avoided. Halogen-induced hepatitis. Hemodynamic goals: avoid hypovolemia and hypothermia, avoid vasodilatation to prevent low peripheral perfusion pressures, or donation and intra-blood vasopressors to restore perfusion pressure. Central pressure should be maintained within a range of 2 to 5 millimeters of mercury. Urine output should be maintained more than 0.5 ml per kg per hour. We can use colloids in place of crystalloids. Albumin or 20% albumin can be used as it reduces extravascular translocation of fluids and it can improve mesenteric perfusion. Crystalloids can use sodium FFP transfusion at a rate of 15 ml per kg per hour. Packed vessel transfusion. Extubation after the patient is fully awake, fully reversed and extubated.
Okay. So what are the parts in this? Can you read out the full question first?
Preoperative preparation, risk assessment, and anesthetic plan in patient with cirrhosis. For Lienorenal shunt.
Yes. So there are three components in this. One is preoperative
Preoperative.
evaluation, preparation, evaluation. We can combine that together. Risk management of lienorenal shunt in a patient with cirrhosis. So the first description that you give here should be why this patient is posted for lienorenal or splenorenal shunt. That means there is an established portal hypertension in this patient, isn't it? So what is the risk of portal hypertension? Why you want to reduce the portal hypertension?
Uh,
Hmm? What will happen if the portal pressures are consistently high? What are the bad effects of persistent elevated portal pressures? Vidya, Trisha,
Increases the risk of gastric varices.
variceal bleeding. Very good. First and foremost, because the portal hypertension will develop a lot of variceal connections at the esophageal junction, at the rectum, and other places. Most commonly, it will cause erosion of the gastroesophageal venous plexus, which will become dilated, and patient can develop very life-threatening hematemesis. Okay, and the other thing is untreated portal hypertension can develop or produce hepatic encephalopathy because all the toxins enter from the portal circulation into the systemic circulation through these communications, and the patient may land up with hepatic encephalopathy. These are the two reasons why they try to create an artificial communication between the portal circulation and the systemic circulation by surgical method, and one was portocaval anastomosis, direct communication of portal vein to the IVC, inferior vena cava. Another method is to make a communication between the splenic vein and the renal vein and reduce the portal pressure, thereby reducing the severity of the gastroesophageal variceal dilatation and avoid the injury or rupture of that and producing a life-threatening hematemesis. So this part you should prepare like a patient with advanced stage of portal cirrhosis liver who has already developed portal hypertension. So preoperative evaluation should look into all these factors and also other effects of portal hypertension like portopulmonary hypertension, hepatorenal syndrome, which are all quite common in these patients, which can also be present. So if these things are present, then the morbidity and mortality is quite high. So that also should have to be taken into consideration while making the evaluation of the patient. And then you must stabilize the patient. Then the next, after evaluation, the next component is risk stratification. And in writing the answer for risk stratification in this particular case, you don't have to mention about the MELD scores because MELD score is mainly for selecting the patient for liver transplantation as a final treatment for end-stage liver disease or cirrhosis. Whereas here, the question is only about the splenorenal. So a passing mention that MELD score is used for selecting the priority for liver transplantation. That is one line can be just mentioned to show that you know about it. But the main scoring system here is only the CPT scoring system. And there is another scoring system called ALB scoring system. Have you heard of that ALB scoring system? Tisha?
No, sir.
No, sir.
Albumin and bilirubin scoring system. Okay.
Yes, sir.
So that any one of them can be used for assessing the risk involved. Then based on the risk, you must next talk about the optimization, how best you can prepare this patient. And our goal for anesthesia is to avoid sudden hypotension and precipitating an acute liver failure on the scenario of a chronic liver failure. That is the most important thing. So all the time we must maintain and preserve the hepatic blood supply. And as you know, hepatic blood supply is by dual supply coming from both the hepatic portal vein as well as hepatic artery. So the hepatic artery is supplying most of the oxygenated blood, whereas the portal vein supplies the brings the nutrients from the intestines to metabolize. At the same time, it has only a 40% oxygen saturation. But this organ is unique that it has got a dual blood supply, and that should be preserved to prevent a acute liver failure on the table. And they can have coagulation difficulties, which you have mentioned, and you must be prepared. And this being a vascular surgery, you have to anticipate. Sometimes there may be a clamp slip or a surgical difficulty. When you dissect out the vessels, there may be some bleeding. So being a vascular procedure, we have to be prepared for
privilege pass இதுல போடல
pardon.
அப்படி போட முடியுமான்னு தெரியல.
Duraraj, please mute your mic and talk, please. Your mic is on. Please mute your mic. So that is how you must present that. And the lienorenal shunt is done, as I told you, between the splenic vein and the renal vein in a end-to-end manner or end-to-side manner. Okay, so these are the procedures that is done. I will just show you the PPTs for both the preparations, and we will see how to present this. First, I will go to